vibe, come pull up a chair. There's room at the table, good stories to share. It's OG and I'm that Beth in your ear. We fill it with love and spill it with cheer. From the food truck flame to the therapy couch, we seen a lot, got some truths to shout. Talking mental health, hearts, and late night feels. All the real talk, nothing concealed. We laugh, we learn, we go too deep. Sometimes the tea's too hot to keep, but we're here, no shame, just chill. Grab a snack, let's talk what's real. Welcome to the Fill and Spill, where the combo's hot and the vibe is real. We fill your plate and spill the tea with honesty, heart, and a little therapy. Yeah, come hang for a while. It's all love, all laughs, all style. This Fill and Spill.
OG. Hi guys. And today we have some very special guests. One that I'm very familiar with, I will just say. Please welcome my mother.
Mama G.
Hey, I'm Donna. And our special guest.
I'm Lauren Shurson, owner of Storyline Health Navigation.
How you doing, Lauren?
Doing pretty good. We're here cozy on a cool day.
All right.
It's great.
We're very excited to have everyone here with us today.
Yes.
So, Storyline
Mhm.
Health Navigation.
Yes, ma'am.
It's a very unique name. Tell our listeners what it is you actually do.
Yeah, so we are a patient advocacy and health navigation service, which is a lot of words that people may or may not be really familiar with. But at the heart of it, what it is, if you've ever been to like a doctor's office and you're like, you didn't read the chart, you have no idea who I am, or you're just reduced down to a whole bunch of bullet points. What we do is we create you as a person are full of stories, and you are not just bullet points. And so what we do is we help advocate for you by really allowing your provider to understand who you are, where you've come from, and also really importantly for medicine and health navigation is that you have to know where you want to go. Not everyone has the same outcome in mind. For some people, it's I understand I have an illness, but I don't want to take medication. Or it might be, I have an illness and I want all the medication, right? Like just kind of basic. And I don't know if you guys have ever had the experience of actually, when you go to the doctor, if anyone has ever paused to say, what do you want to get out of this? Because there's just not a lot of space for that, right? In 15-minute appointments, usually we spend about 7 minutes with the patient. The rest of it's on documentation. And then 7 minutes, you have to figure out what symptoms they are, try and figure out something, and you throw together a plan, and then it's done. And you might leave and you're like, I have all these questions.
Right. Some people don't know what to ask, right?
And it takes time. I think that's not unusual, right? And so
Right.
a lot of times, because you're just trying to figure out of like, am I dying? Am I not dying? Is this life altering? You have to get through that, but by the time you just get through that first pass again, then it's done. And so to know, actually, that's why people get home and then they turn to Dr. Google, because it hits you that you're like, well, snap, I should have asked all of these things. A little bit is a secret. I don't know how much of a secret it is, but providers, I work with them all day. And when we actually have to go to visits, all of us, when we swap stories, are like, well, I totally forgot to ask about XYZ. And we have that question, right? Like if we have it, yes, we understand probably what the diagnosis is, what the medication is. That doesn't mean that we know how that fits into us and our life, and we're asking for that guidance. And so then if you are a patient without a medical background, you're still stuck on what is this thing and how do I pronounce it? And then you just shuffle and repeat and rinse, and you never get to the deeper questions. And so that's where, again, it's the story of you have to know. A lot of plans fail, we know, by research, which research is not in like normal life usually.
Right.
Is that we know that patient desire is actually very important for like, will you actually stick to a treatment plan? Will you do, like, will you follow it? And I would say my lived experience is a lot of times people won't follow a plan because they never understood it, right? Not that they're like, oh, I'm just going to be a bad patient. In fact, we actually know by research that most people want to be good patients And then you have this weird guilt thing layered into it. And then that just causes even more separation between you and your provider. And that's hard when it's something like, I don't know, hypertension that's relatively like you can take one medication. But if you are at a transition and crossroads of like, this is a serious illness layered with multiple illnesses, with multiple treatment plans, that just gets more and more and more buried and lost. And we lose you as the person.
Well, and we also know, right, with medicine, it's a lot of trial and error because the medication that worked for your sister or your mother or your aunt or your father does not always work for you.
Mm-hmm. And that's true. So we're getting closer. There's something called precision medicine, and sometimes we can run a test to predict which one you would respond better to.
Mm-hmm.
That being said, even if you respond better to it, but you still have horrible side effects, is it still a right fit, right? Or if you are, I don't know, a truck driver, will you be able to actually do a medication that's 4 times a day? And so the whole like perfect is the enemy of good is I could choose the one that might technically be better for you, but if it's 4 times a day and you can't take it, then that's still not good. And so there's so many layers and reasons why, even if we have a drug test that will say you will react better to this drug, there's still more to it than that. And that's what gets lost. And then people just get frustrated of, I'm never listened to. And we know that, and especially depending on different populations, just because of really bad history, there's already a level of distrust with the healthcare system because of what was done. And so if you build lack of trust on lack of trust, and so what I think you're starting to see is people are turning to ChatGPT. That's actually a very hot topic right now, and OpenAI just did basically a very specific for health. You can integrate your medical records and it can do it. And so medical professionals on one side are like, why would they choose ChatGPT over me? And I think we have to be realistic that patients are really sick of being rushed in a visit, not getting real answers. Also, it is really important to note that we know people change their health decisions based on anticipation of the healthcare system. And so if you think that a service will not be covered or more expensive, you will self-regulate and opt out. So we know that that happens, but we also don't talk about it. So again, that's where that non-compliant patient comes in, and the patient's like, I'm sorry, I can't afford the $500 test that you want me to do. Like, sorry, but it's not an option. And so of course they're going to go to the free service, right? Like I don't think we should judge that. I think we need to say, why are people doing it and what do we need to do better?
Well, and also too, right? Like you can talk about even the white coat syndrome, right? Because we never know when people come into the room what they're already bringing into the room, right? Because it could just be that somebody is anxious, right? And most of us who have anxiety with the racing thoughts and things, how are we going to think of those questions in the moment when we need it?
But how do you deal with people that have a phobia per se
Yeah.
of doctors?
And I think that's where, if I can help you prep, so one of the big things that we do is it's more of a discussion like this, right? So one of the things that Storyline does differently, instead of no one has time to read all of your medical records. I think that's another thing, right? So before we start really getting into you, we do all of your records and we compile it. And then we ask you, hey, this is what I see. Does that match your expectation of what you think I should see, right? And there's lots of different reasons for that. We know there's very wide ranging estimates on this, but we know that most medical records have anywhere between 20 to 70% is kind of what I've seen of medical errors in every single chart. So, and a lot of that is because of automation. How often have you gone into the doctor and they're like, are you taking the same thing? You're like, yep. And no one actually cross-reference what their list is to what if you saw another doctor, that EMR doesn't actually update into their EMR. So you have multiple different lists. And then also another important thing on meds is that if your provider didn't actually cancel the prescription at your pharmacy, they're going to keep refilling that.
Yes.
And so if you didn't actually call your pharmacist, they might just be refilling and you're still taking what someone else thought you stopped. But that's why you see, and then it's like a game of telephone, right? Someone and they don't have enough time to really go line by line of what medication, and even if you go line by line, are you taking it the way that it was prescribed? Are you still taking the same dose? Are you modifying for some sort of different reason? Right. So all that to say, like, it very much is, no one has time, and we need to actually have the time to first do the research and then have a conversation back, instead of like, can you perfectly describe your symptom and your diagnosis and when it happens? You have to flip the script. So we come to you, and then, hopefully it is an environment of, it's not at the doctor's office. We do this over Zoom. We can come to like an assisted living is one of the ways that we do this, and then we can have that conversation in your home environment. And telehealth gets there to a degree, but if telehealth still mimics the clinic and isn't something else, you still get the
Right.
fractured relationship. And so the approach is different.
Oh, that's interesting. Wow.
Yeah. So the very fancy way of saying this is that there's a movement towards narrative medicine.
Right.
And narrative medicine is, again, you hear different phrases over time in the research of like holism or holistic medicine, but you're seeing a huge rise of is root cause medicine. And that really is, again, just going back to, you again have to know where you came from and where you're going.
Right. And for our listeners out there that want to be in your field, what advice would you give them? Like, what schooling, licensing do you need to be in the field that you're in?
I think a lot of people can actually do this now. I don't think it has to. I'm a nurse practitioner by trade. I've been able to start connecting. There's a lot of us. Another best kept secret. I don't think people realize how much the provider on the other side of you is just as frustrated as only offering you the 7 minutes.
Yeah.
And they're sick of it. So I've seen MDs, therapists. I've seen just a lot of people, and really what the skill set is of, you do have to have some sort of degree that allows you to understand medical terminology, because a lot of this is a health literacy tool as well. So I have to understand what's written, so then I have the ability to translate. But I would say I'm very big on, there's too many silos of like, you have to have this type of medical degree to do it. It's more, I think you have to have a passion for the real life experience of your patient and what happens to them in life beyond the walls.
And see, the
That's
problem is though, right, is that we run into is with doctors, therapists, right, it's all treated like it's a business,
Yes.
right? So your notes and documentation is you're checking off boxes, right? And then like in my line of work, one of the things is that we can be subpoenaed for court, right? And so the way I treat my notes is I make it very, very general. So like if anybody read that note, they're really not going to know fully what's going on due to my occupation,
Yeah.
right? Because unfortunately, I have been in the scenario where parents getting a divorce want to take the notes to court and use that, right,
As leverage.
as leverage.
Or
And so I have to do what's in the best interest of my client, which is the child, and I have to protect the child.
right.
And so that's where you have to kind of be careful with those records, right? But if you're billing insurance and you're doing all those things, that's where it's like they want to make sure, what intervention did you do, right? How was their mood? How was their presentation? And that's where you go and check off the boxes. Whereas like with what you're talking about, the narrative part, right, is being able to have a full compass of the story. So where maybe we wouldn't have to do all those checking of the boxes and those things like that.
Right.
So that we have a better picture and a better way to treat our patients.
Yeah.
Yeah.
And I think that's where one of the rubs of, even if your provider had time to read it, what you're saying is fascinating is every profession has the why we write the note, the way we write the note. So if you look at my note versus a physical therapist note, there's commonalities, but they're actually quite different. And my notes are usually actually written for the insurance company there's like levels of coding that you can do for a visit, and it's to establish the insurance justification for the billing. So it isn't a patient record for the patient, it is a patient record for the insurance company.
Sure.
And I think too. I mean, I'm the older generation here, of course. And I think we live in such a fast paced world now that people my age, older than me, when we go to the doctor, we want you to sit and listen to what we have to say.
The need.
Right. We want you to listen to what we have to say, and that
some
doesn't
doctors-
happen a lot of times.
Right, it's because some doctors look at you as like a statistic, or like
Or as a woman.
or as a woman, yeah, or there's my parrot. we have this inside joke.
Yeah, we have this inside joke. We call each other like the parrot because a lot of times we'll say the same thing that we're like needing.
Love that.
Yes.
It's like
That's how
close
sick we are.
bonding right there.
Yes, the ADHD definitely at its finest.
Kicking
But
in.
it depends on the person too. I mean, not everybody is open when they go to the doctor. They don't
Yeah.
like to tell. They don't like to talk about it, you know.
Mhm.
So it depends on the person too.
And I think that's where we're really big on. I like having the assumption that hopefully the provider on the other side wants to talk to you, right? But because of the system, they can't. And so doing that, a lot of, if I can sit down and have that long form conversation with you, but then I can then in your patient portal help you craft. I'm very big. This is like one of the big things I stress in our program is you will forget what it is that you want to say unless you write it down beforehand because the time pressure and everyone's aware of the clock and like the click, click, click. And then also the night before your visit, I would go into your patient portal and outline what you're feeling, what your biggest concern is, and what questions that you have so that you're like, I can't tell you how much providers love that because I can then prep going into the room instead of like, what's behind door number 3?
Right.
I know we can cut through some of the like feeling each other out and get to the meat of what has to happen. So that's a huge part of like, yes, it does take time. No, our current healthcare system is built for it. So you can keep looking for a provider who can do it, but most likely just because of the system they can't. So let me help you help your provider.
Mhm.
And that's where I think a lot of patient advocacy, you can hate on the provider on the other side, and that's ultimately not what's good for the patient in front of you. So
Yeah.
that's it is a lot of preparation, and hear me say I've seen a lot of resistance is it should not be this way. And I'm not actually arguing that. Like I agree, like I would love for your provider to have that time to do this and that you don't have to have another person, another service to help modify what you should already get.
Right.
But that's just not where we're at. And I think since you brought up older generation, we've talked about continuity of care for a very, very long time, right? The problem is that with shortages, with a whole bunch of different things, even if you want continuity, doesn't mean you'll get it.
Right.
Mm-hmm.
And also, insurance coverage shifts every year. So even if you love your doctor, now they're no longer covered. So now you have to shift. So for many different reasons, and are you going to wait 6 months to see the doctor you want to see, or will you take the visit because you need to be seen in 3 months because that's closer? So we get into this cycle of scarcity. But I think even more so, I haven't seen this as much, and I would love for it to be emphasized, is family practice used to be, I delivered you. So I still see your mom, I see you, and there's this context to family of like for HIPAA reasons. It's not like we would be blabbing about you to you, right?
Right.
Yeah.
Right.
But I can still kind of put that nugget away that I know more about you because of what you might mention in your visit, and it kind of reverberates in this really beautiful way. And we don't get that anymore. And so like you're not known on a deep level, or man, I might have seen you at the, farmer's market this morning and your gait isn't what it used to be. I see you sitting on a patient bed and with no context to like, how are you moving in real life? And for aging, that's a huge thing. Like,
Very true.
what's
Yes.
your transition from sitting to standing? What's your transition of like getting out the door? Do you have stairs? Do you have whatever? And you lose all of that in our current system.
Yeah.
And so that's what we are trying to like build that picture. And again, so that's what's good for you as the patient is good for the provider on the other side. Use their knowledge for that specialty, but also still be seen and known as a person.
That's good advice, people. Listen.
Hopefully, I think it's finding that, and I am big on. For many people, they don't need our service, right? Like, I think it's nice for everyone. I would love for medicine for this to be, but it really is what we've seen as like complex kiddos, like with Down syndrome, that they might have like 9,
Sure.
different doctors, and sweet mom and dad are trying to like organize the
Right.
life, and also getting to what is a goal of care is a little bit hard. We're also seeing this being used more for, again, aging generation of like when you have to involve your adult child in your care, and you might have to, transition to assisted living. You might have to do that. And all of a sudden, we don't practice and make space for what does it mean to make family communication and decision until you're on your deathbed. And then it's like, oh, family meeting time. And you're like, I have no practice, and now I'm in crisis mode. And goals of care shouldn't just be for death. Goals of care should be, no matter what age and stage of life you're in, of who you are and what you need out of your experience with healthcare, is very, very grounding.
Mm-hmm.
So then, what advice would you give to the listeners to help prepare in those kind of situations?
Yeah. One, honesty is the biggest thing. As a fun note, if you guys haven't heard, have you heard of Everybody Lies? It's a book.
It sounds familiar.
It's so good.
Yeah.
So, and sorry for, it's a little bit of a weird example, but one of the like opening examples is how much people report that they have sex versus how much condoms are actually sold and then Googled, because you will tell Google the truth more than you will tell your provider sitting across from you.
Absolutely.
Oh, that
Absolutely.
is so true. Yes.
Absolutely.
Right?
That is 100%.
And so I can't tell you how many times that and then again, it takes time, and we don't always have time, that like on the 3rd visit, I'm like, I've already added 3 beds and nothing's like changing. And then, having to finally pull out of like, well, I haven't really been taking it. Well, how have you been taking these meds? And now I've thrown 3 meds, and you weren't taking the 1 med, but you told me you were taking the 1 med, right?
That's
But
what I'm
you're like,
saying.
man, I don't want to be judged. And so just know, honestly, the provider on the other side just wants to know.
Right. How
That's
are they
it.
going to help
Be
you?
transparent, people.
Be transparent. Speak your truth, right? Like, it's that type of thing. If you're not taking it, say you're not taking it.
Right.
If you're never going to take it,
Be honest
say
about
that.
Baby.
But you're always going to have people like that. I mean, that's just different personalities
Yeah.
and people, right?
Don't suffer
Me?
in silence.
Listen, I'm just the opposite. I tell it all. I don't care.
Yeah.
You know, how am I going to get help if I don't tell it all? I mean,
Yeah.
it's your doctor.
There's
It's your
no
doctor.
shame or embarrassment to be transparent with your medical
They've
provider.
probably seen it
It's-
anyway.
It's probably
Right.
the safest
Mhm.
thing, right? Like,
Definitely.
I mean, this is your health. Like, this is
Probably
for
heard
you to live a
and
long
seen
life.
so much more.
Yeah.
You know?
And it's one of the reasons, again, I'm a big proponent for taking that 5 minutes the night before to put, like, if you're struggling with, like, man, should I actually say that I do this thing? Get it out. Get over your butterflies, because the other thing that I see of then it causes dissatisfaction is it takes you up the entire visit to get the nerve to say the thing, and then I have to go because I have 3 other people waiting for me.
Right. Right.
So again, that like the writing of it also helps you organize like where you've been. But again, it's not just writing it; it's writing it with a, this is still my question. Like, that's my biggest thing. These are still the questions I have. This is the thing that I don't want to say out loud. If you answer those 2 things of why you're going, it helps a lot. One that I see often is, do I actually, and it gets into interesting family dynamics too, of this conversation of if someone should continue to drive. Because driving's not just about driving. Driving's about freedom. Driving is about like independence and just being an individual personhood, right? Like that's, but everyone is scared to say it because they don't want to know the answer, right? Like, and that's probably one of the biggest. So what happens is like you go home and you see the family tensions rise because someone's going to say, well, I just don't think you should drive. And it's like, well, the doctor didn't say that. And it's like, well, you didn't talk to the doctor about it. So then they weren't able to be a referee for a really hard conversation.
Mm-hmm. Yeah.
And so, yeah. And that gets into, too, we see it a lot with, again, as people get older and involving like adult children in their care, one of the tensions I see a lot is, a lot of times it's the daughter, is really wanting to be like, I'm taking care of you, therefore you must do X, Y, Z. And the other person's like, I'm just done. Like, I don't want to do that thing. Right?
Sure.
And then
A lot of us have parents like that. Like, our parents, like, they're so used to being independent that when you tell them, like, hey, it's time for you to move, or it's time for you to, like, move to a warmer climate for your body. Like, you know, my mom, for example, she has arthritis, like bone issues, and I tell her all the time, like, you know, you gotta get out of New Jersey and come to North Carolina. The weather's a lot better, and you know, it's better for your health.
Stubborn. And I think even just having that conversation of like, are you losing the community that you've had for
there
forever?
you go.
Right? And I think that's where, again, all of these things get to be a tangled ball of wax to a degree, in terms of like, because our communities are built the way they are, then we also, it is hard to like financially, of like a move to New Jersey to here. I don't know exactly how expensive, but I mean, we recently moved
It's expensive.
we moved from Phoenix here, and it was like 20 grand.
Yeah.
So like, can you do the thing that you want to do anyway? And if you do want to do the thing that you want to, but all of that, social workers, there's not enough of them. So that's really for the really hard cases of like, they're, you know, helping people who don't have housing stability leaving the hospital. But that means for the rest of us that these are really big, very present needs, and there's no space for it right now. And so that's the other thing, is that a lot of times storyline turns into like, we're kind of the social worker, we're kind of the insurance navigator, we're kind of the healthcare navigator, like with your actual thing, because all of those things, we know health is a conglomerate of all of those things, but we don't have any space for the fusion of what health actually is.
Wow. That's interesting. I like this.
Thanks.
Well, I think also too, right? Like a lot of times insurance, it's so difficult because you're going back and forth with them constantly. And not only that, but also too, you know, with out of network, right? Like a lot of times they just don't want to pay.
No.
They
And I
don't
think
pay.
you have to know that. So for stats, we actually know that it's almost like 80% of claims have some sort of inaccuracy. So I think people get the surprise bill and they're like, well, crap, how is it that much? This can't be right. Most likely, yeah, it can't be right. It's not right, because we use like AI algorithms to do it. So I think that's another thing, is we know that caregivers on average spend like 23 hours per week. So it's a part-time job to help care for whoever they are caring for. And a lot of that is going back and forth with insurance. And like, you have to be prepared. You have to write down, if I call, do I have the reference number? Just as a personal example, we were going back and forth with some dental stuff for my kids, and they're like, you never called. We have no record. I was like, here's the reference number. And they're like, oh, yeah, we now see that call. And you're like, yeah, of course you do. Friend.
Yeah, now you see it.
Now
that
you see it.
I
Thank you.
pointed it out for you.
And you kind of have to be a little bit, it feels mean, I'm not going to lie. And so like, being in this world, I'm like, no, I need this escalated and I need it taken care of now. Like,
Well, it's not just necessarily being mean, it's about being assertive,
that's
right?
but I think people are, again, afraid of like, man, I
Sure.
don't want to look this way.
Sure.
But
sure.
just know, like,
No, I don't have that problem.
that is a good not problem to have.
I don't
Yeah.
mind being mean.
And it's good because I think that you're not just fighting for it, like that one visit with that one diagnosis.
Yes.
You are literally fighting to get that taken care of, so that unlocks like the next steps in
Right,
care as well.
right.
Correct.
So do that fight. Don't be afraid to do it. Call when you have a question. If it doesn't look right, you think it doesn't look right.
because there's so many people that do not get the help they need because they are afraid to speak up.
Mm-hmm.
They are afraid to say what they really need, and if you can help them figure that out and help them figure out what they need to ask and what they need to get better, then that's great.
And the one thing I do, like with any of my clients that are doing out of network claims, any of that kind of stuff, right? That is what the insurance commissioner of the state is for. They are there to step in. So when you are really having a tough time and you have gotten the 10th denial of a claim and it should be correct and your providers are saying everything is good, that's what they do is they step in. So call your insurance commissioner of North Carolina and file a complaint. And they will call and be like, hey, you're supposed to be doing your job. And then all of a sudden the insurance companies are now nice.
All of a sudden.
All of a sudden, right? Just like that phone call.
But you have to know, like, that is the game. They are assuming you won't call, and they will do what they can to not pay. Like, just know that going into it.
But there's a lot of people that don't know who to call or what to do,
or
right?
even what questions to ask when they do call.
Yeah.
Like, I think
Again,
that's
speaking of
that's
being
a
assertive,
struggle.
is I see that this should be covered. I did this, and why is this not being covered?
Right.
Like, I know that seems simple, and it won't fix it all the time, but those
Sure.
couple of questions will get a good amount of it. Is that I see this as a benefit. You are saying that you are not covering it. What they will say is like, oh, the adjusted rate. And it's like, well, no, you are contracting with this person. So, like, I should not be balance billed for this amount, or you need to tell me what the balance bill would be before I make that choice to go.
Yeah.
Like, those are a lot of the things. I am excited. There's a lot of work. Direct primary care, if you guys are familiar with it, I think
Yes.
you know someone.
Yes.
So for those who aren't, it's basically saying maybe the better choice is to get catastrophic health insurance for if you're in, the hospital, car accident, you get cancer, any of those things. But for direct primary care, you do a monthly fee, and everything is covered in that. So, like, it doesn't matter if you have a kid who had an ear infection that didn't clear and all of a sudden you're having 3 different visits with multiple tests, all of that will be covered with your membership.
And so the marketplace this year are no longer doing catastrophic plans. So because they're trying to, of course, force as many providers that they can to go into in-network.
And I think this is, muscle memory. I say catastrophic, but I would say like your high deductible plan would be the, so
sure.
I've seen a lot of do high deductible plus do the membership, and
Yes.
crossing fingers, more and more we're seeing HSA be able to cover DPC membership fees. In the past, that was a huge no-no. However, even if it doesn't cover that, the cost of your membership plus the high deductible is usually what you're going to be paying for a better plan that still has a lot of question marks at the end of the day of like, how much will you actually cover? So that's just a tip to consider as if you can. It's not always the best choice for everyone. So like one of the NPs I work with, her and I batted around this idea for a bit, but she has type 1 diabetes. And so the pull is of like, but she's also an NP and a diabetes educator, so she can probably make up for like with the endocrinologist. But for her, she chose not to do it because she wanted to still have better access to endocrinology. So again, just know of like how many specialists you use. But this is what I had said before is a great option. If you don't have a lot of specialists, you predominantly only use primary care, urgent care throughout the year. It is a great choice to do high deductible plus membership for a direct primary care. For those of you in Wake Forest, we have a couple. So you're starting to see more and more. And a lot of the things that I love about it, because the membership model at most direct primary care, speaking of time, they usually have it so that you do spend 45 minutes to an hour for each visit. So one, it's probably a wash of cost for you, and you still get better care.
Nice. I do know some people struggle with picking plans that fits their need. So what advice would you give when searching? Like, what do you look for when choosing a plan? A lot of people don't understand like the basis of the coverage per se. Like if it's 20%, in network versus out of network. How can you explain to our listeners or any advice that you would give when they're searching for a plan, even if it's with their employer?
Yeah. And I think this is huge. It's a great point of, we know that medicine itself has a language unto itself. In our country, you have to know the language of medicine plus the language of healthcare system.
Right.
And that is terrifying. So I would just say it is good to look. Most companies now offer someone that is like a representative for your company to that insurance plan.
Mm-hmm.
Yeah, that's me.
That's you. If you don't remember who that person's name is, you can call your HR. You should know how to get in touch with your HR.
Your benefits center, basically. That's what she's speaking of.
Yeah.
Is your employer's benefits center, basically.
Yeah.
And their reps will be able to assist you to better understand your coverage, what plans are being offered, so on and so forth. Not to take
I was
away
about to
from you.
say, I think you should
I should have
answer
asked
this.
that question.
I will ask this question back.
But
What would you recommend?
I mean,
since you take this call?
sometimes like explaining the benefits can be hard at times for reps. They go off and like reach out for assistance because some of the plan rules aren't written in plain English, like it's written in Old English, and you have to like literally put it together. It's like looking for things, needle in a haystack, almost, like to find things in companies. In companies' plan rules, and it's like, where am I looking for this? And it would be like a huge document that you got to go through, and just to help answer some questions. But yeah, I think a lot of people struggle with finding what plan to pick.
I take a very pragmatic approach to this is that I think that knowing both sides have risk, and I would say that I've been on high deductible, I've been on not as high of deductible plans, and honestly, you're still paying a lot with your copay, and you will get a balance bill afterwards. Like, I don't think I've ever in my adult life not gone to a visit where I haven't gotten a bill after. So I think the question is on a very, like, you can get into the weeds with a lot of this, but it's if I have a car accident that is major tomorrow, do I have enough funds, and will I be in an okay place with the deductible, which is like what you're kind of on the hook for before they start covering everything.
Yeah.
I boil it down mostly to that. And the other thing that I think is most important to people is you should be able to look at what doctors are contracted with each plan.
Mm-hmm.
And again, if you can't tell, my bias is towards continuity. So if you can do a plan that you can keep your same doctors, I think you can get into the weeds of it. But I think, and this is where there's a lot of swirl right now around like health pricing transparency.
Mm-hmm.
There's not transparency is the answer to it. So you really have to know of like, how much am I okay being on the line for if something big happens? And that's usually, honestly, how me and my family make that decision. It's not very glorious of a plan. It's pretty basic, but I think it comes down to, can you see the provider you want to see? If you have a provider you need to see, and how much financial risk are you willing to kind of gamble on it?
Oh, that's great. Yeah, that's pretty much where I was going with that question. Like,
Yeah. Because, well, like what you said, if you actually look at your summary of plan document,
Mm-hmm.
it is intentionally legalese. It is intentionally super long with lots of if this then that statements.
Yeah.
You will not know their algorithm until you get there, unfortunately.
Yeah.
Oh, my other big advice is that if you are in a high deductible plan, always look at cash price pricing. Cash pay.
Words
There
are
we
hard.
go.
Words are hard.
Words are hard sometimes. I need more coffee. Cash pay pricing. There we go. It's the double P. So a lot of times it will actually be lower than the amount that you will then have to pay significantly. So a good example of this, if your copay is $50, but you can anticipate the balance billing at the end of it, and it would have if their cash pay pricing is like 75. Is it worth it for you just to pay the 75 and be done with it and not get some sort of bill for some sort of amount afterwards that then comes? And because of the life cycle of a bill, that bill could hit 3 to 6 months later. And I think financially, when you're thinking about budgeting, that's really hard because there could be a big thing and I don't know exactly when it's going to come. So cash pay pricing, and especially if you need CT, MRIs, and all of that jazz, usually what you will be responsible for versus the cash pay are drastically different. The other is always ask if it is under a hospital facility fee or if it is on a true outpatient. And so imaging, literally, if it is like somehow under the hospital tax code and all of that jazz, it could be $1,200, but a lot of times it should be around $350 is kind of your going price. So it is worth it for a lot of people to just pay that $350 and be done with it. Then again, how much,
like how they're running it through.
Yeah.
yeah. Which, hear me say, the rub there is that I think all of us are like, I am paying my premium every single month. I shouldn't also do the cash pay. Again, it's about your financial risk approach.
Right.
Again, this is where healthcare navigation has to be at the intersection of all of these things. The NPs that I work with, all of us have had very strange jobs. I thought I would learn more by working for the insurance company side of things. I was on population health, trying to keep people out of the hospital. I was not on this side of it, but I learned a lot about health care insurance by working for it. A lot of us have worked for like FQHCs, which is like grant type stuff, hence that social worker aspect of, please hear me say, we are not social workers and not trained that way, but we learned a lot by working with our colleagues with it. But not every provider is a good fit for Storyline either, just as not every patient, because I very much vet out for like, you have to have those weird experiences that would have allowed you to see what happens to patient when they go home. That's really what we're there for, where medicine hits home.
Okay.
What has been the most rewarding part of your work?
I think that it is, and again, this is why I'm so big on looking at the provider on the other side of a person hopefully wanting to do the right thing and maybe being too burnt out to do it, is I think that all of my NPs, myself included, and how my weird journey started is I became an NP very, very young. So then I had hit 30 and had already been in medicine for a while, detoured to academia, then detoured into healthcare administration. It's a very weird path. I wasn't sure if you could find a place of like why I was called to medicine to be able to practice the way that I wanted to. And I think that one of the saddest things about our current situation is it doesn't serve the patient, it doesn't serve the providers, it serves no one. And so one of the things we're passionate about is very much making it a place that both sides can do what they were called to do.
Yeah.
Can
To be
benefit
human.
from it. Yeah.
Yeah.
The benefit part.
The benefit part.
Yeah.
Because most of us want, like, there's a reason why we got into medicine, right? Like, we care deeply for people, and I think you kind of forgot to care at how to care at a certain point of it just being, you have to survive at a certain point. Like, there's only so much you can take of 7-minute run-throughs with patients and then having to, pajama time chart at the end of the night, and you're just tired.
For those of our listeners who might be having a hard time on their own healthcare journey, what advice would you give to them?
Yeah. Even if you don't want to, because it's touchy, again,
Sure.
to have to do another person. So one, another thing I'm big on, this is a big enough problem. There's lots of different flavors of patient advocacy now. It can be through caregiver groups. It can be through patient, of a diagnosis group. Find a community who understands so you know the questions you need to ask. Again, knowing what questions to ask is probably one of the biggest things. Find someone. What we do know is that even at the best of times, retention after visits is only 50%-ish, right?
Wow.
It is normal to forget and not remember because your brain is trying to process what they're saying, but your brain automatically goes, what does this mean for me? And it crowds out. Like there's only so much you can do in that time. Have someone who is consistent who can come with you to visits. I think that's huge. There's actually some people who say that everyone should have some sort of advocate when they're in the visit with them. And part of that is it is normal to forget. You will not remember. A lot of places may or may not allow you to record. Some people will.
Right.
So that's another thing you can do if your provider allows for it is videotape the thing so you can replay it. I actually connected with a doc in Phoenix who she is part of a big Indian family and she's a doctor. So she's supposed to remember and caretake and everyone's like, well, what does this mean? And she's like, I didn't hear the conversation. So there's something called the Caretaker app and it'll transcribe and give you a PDF of the transcript of the visit, but then it doesn't retain it. So then, especially if you are the caregiver or you want, most of us have families who want to know about us and what was said, who said what, you can distribute as you do or do not want to distribute. And that also allows you of if you do have a family or a friend person who is in healthcare who can help you translate and bat around questions, that is a good way to be able to do that. So find a tool, person, thing to allow you to help to translate and to remember. Those are probably two of the biggest things. ChatGPT, some of my healthcare professional community will hate me saying this, use it. Like, know that it will hallucinate. Don't always trust it if you read through what it says. But you can freeform of like those portal messages. Hey, I need to arrange this so my healthcare provider can understand it. Here's my patient speak and have it spit out a summary. Use that, paste it into the portal. So it's some sort of tool to, again, the remembering of and the translation of.
Wow.
Well, and I think it kind of comes down to, right, like the importance of all of it is it takes a village.
It does. Mm-hmm. Yeah. And hear me say, like, no matter if you're a nationalized or whatever we are, like, it's a weird mess out there. Everyone is making, like, my sister-in-law lives in England, so she gets to experience the other side of it. There's some very good things. She's not having to figure out how do I pick my plan? Take that element out. The nationalized healthcare system is still having to do, how do I get this many visits at this fast a turnover and how much of an expenditure can we do? So there's actually very similar patterns. And she still calls me after like my niece goes into a visit, right? Just know that that is normal and not so isolating to us, but it is about some of the societal norms and villaging that have been broken down. And don't turn that into self-doubt or ridicule of like, oh my gosh, I'm just so dumb, I don't understand this. No one understands it.
Mm-hmm. Absolutely.
Right.
Absolutely. Such a lot of information today.
I'm sorry.
Yeah.
It's okay. No.
Like,
No.
This is awesome. I think a lot of people benefit from this, and we're so happy that you came.
Oh, thanks for having me.
Thank you for coming. Yeah, guys. Beth, you want to take over?
We appreciate having you on today, of course. And it was a lot of good information and a lot of things that are not normally talked about that need to be shared with lots of other people. And of course, thank you, Mom, for joining us as well.
You're welcome.
Thank you.
And stay tuned for the fill and the spill. Bye, guys.
Oh yeah, fill it up, spill it out. Oh yeah, fill it up, spill it out. Oh yeah, fill it up, spill it out. 'Cause OG and Beth know this about it. Da 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 da. Welcome to the fill and spill, where we laugh to laugh. We fill your plate and spill the tea, and spill the tea. Pull up a chair, unwind, your family here every time. This the fill and spill. Oh yeah, fill it up, spill it.